Hello, everyone. This is Azhar Hirani. Welcome to another episode of Practice Unlocked. Here I have Dr. Okosun, who is a primary care and runs an independent clinic in Lake Jackson, Texas. So, Dr. Okosun, welcome.
Thank you. Thank you for having me.
Absolutely. Thanks for joining us. So before we get started, please tell us a little bit about yourself, your journey, your primary care position, like in terms of, what did you practice, or what did you, what kind of programs you went through and things like that.
Okay. No worries. So I'm a board certified internal medicine physician. I've been in practice for 10 years, private practice for 8 now. It's been a long journey across multiple continents. I went to medical school in Nigeria. I did my undergrad and my medical school over there, and then when I returned, I did my internal medicine residency at Meharry Medical College, Nashville, Tennessee.
Nice.
Yeah, then I met my wife, who's from Texas, and then she brought me to Texas.
Oh, very nice.
Yeah.
Very nice. So did you go directly into private practice right away, or?
No, so fresh out of residency, I kind of wanted to understand the business of medicine. A lot of times during residency and medical school, you only get to learn how to take care of patients, and you don't understand the business aspects of medicine.
Right.
So I went into an employed position just to learn a little bit more about the operations of private practice. And after a while, I noticed I wanted to do things a little bit differently from what was being done. And a lot of the people in management didn't have a medical background.
Right.
So they were more concerned about numbers and profit and loss and those kind of things. And I had different ideas. So I decided I wanted to do things a little bit differently.
Fantastic.
And I decided to go into private practice.
Very nice. Was it a bigger practice that you joined, or?
Yeah, so it was a practice affiliated with a hospital.
Oh, gotcha.
Yes.
Numbers make sense then.
Yeah.
Why they're after the numbers.
Yes.
But you wanted to do things differently. A lot of physicians do feel that way as well. Do you recommend that? To others, like in terms of work somewhere, gain some experience? I think you worked there for 2 years.
For 2 years, that's correct. I mean, when you finish residency, there's that fear of the unknown. If you go straight into private practice, are you going to be successful? You might have a family, move into a new city, you might have a mortgage. So there's a lot of uncertainties. I've seen some people now go straight into private practice, and I applaud them. I would say probably people should take like a year off, maybe do locums, try an employed position, and just kind of get a feel for what they are doing and what they need to do, and then from there kind of plan and strategize on what to do. Because I mean, they're going to throw different offers at you, especially in residency, sign-on bonus, relocation and all that. And sometimes all that glitters is not gold. You go there and it's something that you can identify with.
Fantastic. So locums, you gave everyone a very good idea. So I see a lot of physicians do locums.
Yeah.
But define locums for some of the audience may not know what that means.
Okay.
So just kind of going.
So locums is pretty much like a temporary position where you're not a full-time employee. So you're pretty much an independent contractor, and the contract length could vary from as short as 2 weeks to anywhere as long as 3 months or 1 year. So it gives the organization and the physician a time to kind of examine each other and see if it's a good fit. And sometimes I've seen people go to locums and actually sign full-time contracts.
Oh, fantastic.
After that. And then people who maybe are still young, single, and enjoy travel and things like that, locum can be a great opportunity to travel, see different parts of the countries or even parts of the world. I've seen people do international locums to places like Australia, New Zealand, Canada.
Wow.
So there's a wealth of opportunities out there.
Oh, fantastic.
Yeah.
So you
get to practice in different settings, inpatient, outpatient, and emergency room or primary care settings or urgent care, and then you can kind of get a feel for the different environments and see what appeals most to you.
Oh, fantastic. So tell me your journey of like starting a new practice, financing. How did you did you already earn enough to, get into the practice, or you went to a bank, just.
Okay. So it was really tough taking that leap because it was pretty much a leap of faith. Sometimes when people get into private practice, they are either joining an established practice as a partner, or they are buying a practice from somebody who's retiring or who might be sick or something like that. But starting from zero, no patients, no equipment, no staff, it's really tough, and it's a steep learning curve. So I talked to a couple banks. I did have some access to financing, but I started with a very bare minimum. I kind of kept things lean and slim. I only had 2 staff. I started off with an office of just 1,200 square feet.
Oh, wow.
And just started grinding and building block by block.
Wow. So if you had to do it over again, would you go the same route, or you would do things a little bit differently?
If I had to do it all over again, I probably would have gone straight into private practice after residency. Mm-hmm. But like I said, because of that initial uncertainty, and you don't know if you're going to do well, if you're going to like the area, if you're going to have to move and things like that, people typically go into an employed position first. But the research has shown that greater than 60% of physicians leave their initial position after residency within 1 to 2 years because, like I said, things are sold to you in a different way, and when you go there, it's not a good fit, or the physician's circumstances might change, and they need to move, or they need a different setting. So sometimes that happens.
So in terms of marketing, how did you market your practice to get it?
So I did a couple of things. I went around introducing myself to the doctors in the community. I went to the emergency rooms, and that's how I actually met you guys. When I went to Altus, I went to schools, I went to different groups, I gave different talks in the community. So I gradually started introducing myself to people. I did some internet marketing. Mm-hmm. Through Google and some websites as well. But a lot of my business and a lot of my growth, I would say, comes from word of mouth. So when a patient comes in, they have a great experience. They go tell their husband or their mother or their father. So some families, I see like 3 generations of people. I see the son, the grandson, and the grandfather, and everybody. So a lot of our business comes from referrals and word of mouth.
Fantastic. So you started off with 1,200 square feet.
Yes.
Where are you now?
Okay. So like I said, when I started off very lean, trying to keep the overhead very low to get through that initial rough patch. So I started off with 1,200 square feet and 3 exam rooms. But within 7 months, I had outgrew the space. So I had to move to a bigger office. So I moved to an office with 2,400 square feet. And then in another year, I outgrew that space. Mm-hmm. So at that time, I was approached by a physician in town who was retiring, who owned the office building. And he asked me if I wanted to come take over the building, and that's exactly what I did. So we moved into our own office building, which is about 4,000 square feet.
Oh, wow.
That's where we are right now.
Yeah, it's more than 3 times the space now, right? Within 8 short years.
Yes.
So I love that you said you did grassroots marketing.
Yes.
Hard work on your own, went by office to office, introduced yourself. I'm sure you had to go to that office more than once.
Yes.
Lunches.
Yes, you have to do that. Sometimes the front office staff are very protective of the physician or the people who work there, so you have to be nice to them. Like you said, take fruits, take meals, and it's a gradual process because you have to earn their trust. Nothing is given on a platter of gold, so you have to earn their trust and earn their business and earn their confidence.
So as a primary care, how does that work for you to go to your so you probably go to your specialists, not other primary care offices, to introduce yourself, correct?
I did a little bit of both. I did go to primary care offices just to let them know that I'm there as a resource. I know a lot of them were not very receptive because they viewed me as competition to them.
Yeah.
But I do have some great relationships with the other primary care physicians in town because there's more than enough to go around. And actually, I've been approached by 1 or 2 primary care physicians who are retiring to take over their panel of patients. So over time, you develop relationships. Sometimes I've had to cover for them when they've been out of town. Sometimes they've had to cover for me. So I would say we have a very great collegial relationship.
So that's how you presented yourself as well. That, hey, I'm a resource.
Yes.
And if you ever need help, I'm there for your patients, and I'll give those patients right back to you.
Yes. And because I'm internal medicine trained, I get to see a lot of complicated cases that sometimes the family practice guys might not be comfortable managing. So it might be somebody with very, very bad diabetes or COPD on oxygen or congestive heart failure on oxygen. So sometimes they will refer those patients to me to help them manage them, or I'll co-manage those patients with them, or they might call me and ask my opinion and things like that.
So, and also you had said Google marketing. Do you mean like pay-per-click, those ads that you see?
So a combination of both. So I did some SEO, some optimization. I did some Google ads, reviews I baked into. Reviews are really, really, really big. I'll say we have over 1,000 reviews now.
Wow.
Yeah, so reviews, we made sure we had a lot of information on our website. We're very responsive to inquiries. If people are send us messages if we are taking new patients, we make it very conducive for them. We have online booking where they can go online, fill out their profile, choose their appointments, upload any paperwork that they have. So by the time they come to the office, they're ready to be seen.
Really?
Yeah.
What's like I mean, I'm sure you have a very busy practice now. Is there like a goal, like if a patient walks in, you want to be seen by at least like the MA, or like within a few minutes, or unfortunately, the busy practice means some people have to wait. So
for sure, but we have the open door policy where we accept walk-ins.
Yeah.
So I can say this with confidence that we are the only practice that accept walk-ins, pretty much in the greater Houston area. So if somebody walks in our door, it doesn't matter if it's 5:55, we close at 6. That person is guaranteed to be seen. That day. If they are there, they will be seen that day. If they call on the phone, if they're not seen that day, they can be seen the next day.
Wow.
Yeah, so we always keep slots in our schedules for walk-ins or people who are going to be sick and things like that. And we try to also have extended hours as well. So some days we go as late as 6:30 or 7 o'clock in the evening, so that people don't have to miss work because of their appointments.
Fantastic. So, I know marketing never stops.
Oh, no, it doesn't.
So are you planning on still growing your practice? Do you recommend that to other primary care physicians as well, that, hey, never stop growing? There are ways to grow, because obviously medical practice is such a business that, and I'm calling it a business because, it is part of reality that it is also a business, yes, to taking care of patients. But, you can only grow as many patients you could see. Like, there is a limit. But I know there are other ways to be efficient, to have maybe other physicians with you, nurse practitioners, physician assistants, so if you had to grow, and I'm sure you're growing, where do you go from here?
So you are right. You have to realize that, like you said, medicine is a business. Patients are also clients.
Yeah.
And you have to also realize that they have options. You're not the only option in town. So you want to make sure that you have excellent customer service. You have to listen to your patients, find out what they want. And we notice now that we're beginning to have a lot of Gen Z population. People want telemedicine. People want same-day appointments. People want online options, and we try to accommodate that. So we have online telemedicine options where if people at work, they don't want to have to drive over and all that, we can see them over a smartphone or a computer. Like I said, we have same-day scheduling. We have we take walk-ins. We have next-day appointments. And you're right, the amount of patients that one physician or clinician can see is kind of limited. So we're in the process right now of adding another nurse practitioner to our practice. We have to make sure it's a right fit. We just don't hire just anybody. We have to find somebody who understands our philosophy. Patients are not just numbers to us, they are family. We get to develop long-term relationships. So I like to say it's not a sprint, it's a marathon. So we get to know them on a very personal level. I have to say that I know like so much about my patients. I know how many grandkids they have. I know where they work. I know where they went on their last vacation. I try to make it very personable because with healthcare, people are anxious and nervous, and it's not something that they like to discuss or talk about. So we try to make it very personable. We aim for excellent customer service. Somebody that comes in the door is met with a smile, and like I said, they are attended to very quickly to see what their needs are. So we take our time hiring, and that's one of the reasons why we haven't hired anybody till now. We've been actively interviewing, but we want to make sure it's somebody who embraces our philosophy and is a right fit for our practice.
So it's fantastic. So you're a physician, you're very, very busy, but obviously you've grown so much. Do you think it's only the physician's responsibility, or you have like great staff that really brings in the ideas, or like an office manager, because you're out there seeing patients, and you're busy, but there's so much that goes on within the practice. In terms of a perfect practice setting, what are some key components that are needed?
Okay, so I can't sit down here and take all the credit. That will be lying, and it will be unfair to my staff. I feel that the team-based approach is the best approach. Everybody in the team is important. The person that answers the phone, the person that's making an appointment, the person who is taking vital signs at the back, or is giving, administering medication. So everybody is an integral part of the team. And a lot of practices, people are instructed on what to do. They are not told why they are doing it. So we like to add the why. We're saying, hey, this is our protocol. This is why we're doing it, so that you are more efficient at your job. Also to have effective time management. So we do huddles. We have quarterly retreats that we do. So we take out our staff maybe to like San Antonio or New Braunfels, allow them bring their family. We spend the weekend. Because research shows that you spend more time actually with your staff at work than you actually do with your family.
Yeah.
So since you're spending so much time with these people, you want to really get to know them on a personal level. So we allow them bring their families. We have a good time. We don't talk about anything work. We go river tubing. Just do something out of work. Allow them to relax and get to know each other on a more personal basis. We celebrate birthdays. We have a cake, sing happy birthdays. We do draws where somebody maybe every month wins a gift card. We have bonuses for like perfect attendance, an employee who went above and beyond to help a patient and things like that. So we try to make it a family-oriented, collegial environment. We want people to be excited about coming to work,
Right.
and not just there going through the motions.
Very nice. I'm sure you have very low turnover because of that.
Yes, initially I would say that we actually had high turnovers starting out because it takes time to find the right staffs. Yeah, like I said, you just don't want somebody who just shows up and is there going through the motions. You want people who actually want to be there, and who exude confidence, and who demonstrate great customer service, and who have the right skills for the job.
Amazing. So this is the first time I actually heard a physician group going to retreats and things like that. That's very forward thinking. So in terms of where did you learn that, hey, you can go this route? Because it's a very unique concept. I've seen it in businesses, but in a medical practice, this is the first time I'm hearing of it. So did you go somewhere outside your practice to learn these things, to learn new ways of doing business, or how to retain staff or hire staff,
I think
training, the cultural fit, like all these things?
I think a lot of it is from trial and error. And I mean, obviously along the line, some mistakes were made. You learn, you make mistakes in anything you do, you are going to make mistakes. The beauty of it is how you learn from those mistakes and bounce back stronger. So in private practice, we have a lot of competition. We are competing with the bigger name emergency rooms and hospital systems for staff. It's difficult to match the pay that is being offered by those people and the benefits. So you have to think outside the box and say, hey, how can you help to attract and retain good staff? And I actually have staff who have left for higher paying opportunities and actually came back because they found out that that setting, even with the more money that they were receiving, wasn't as friendly and as collegial as it is in our practice. So you have to find ways to be innovative, because especially with the pandemic, when there were a lot of staffing shortages and a lot of these staff were being thrown ridiculous amount of money by different healthcare system. You have to think outside the box and try to be innovative, because it takes a lot into training staff on your protocol.
Right.
There's a lot of manpower hours, a lot of energy invested in that. So you don't want to have to be training somebody new every month and all that. It can be draining.
No, absolutely.
Yeah.
That makes sense. So you mentioned the pandemic.
Yes.
How has the pandemic changed your personal practice and also the healthcare industry as a whole?
I think it has definitely had a profound effect on the way healthcare is delivered. Over the last couple of years, there has been a push towards telemedicine, but there was really not a lot of traction. The pandemic helped accelerate that, because in that scenario was the only way to deliver care. There were people who were sick, there were people who had diabetes, high blood pressure, and all these things. These chronic conditions don't take a break or go on vacation. They need to get the care that they deserve. So it was a steep learning curve trying to start up a telemedicine program, get patients to buy in, get them to understand it, get the right software, get the staff on board with the right training to carry out that telemedicine platform. I think telemedicine is here to stay. Platform. Medicine was about close to 95% of my practice. Now that the pandemic has lessened, I would say it's still maybe close to 20%.
Oh, wow.
But I think it's here to stay, although we need more investment by the health insurance companies during the pandemic. Because before the pandemic, telemedicine visits were not reimbursed the same way for a physical visit. But during the pandemic, the health insurance companies made some concessions, and they were paying at parity telemedicine visits at the same rate for in-person visits. So now with the pandemic going away now, some of the insurance companies are starting to try to revert back to how it was before that. But we're trying to advocate and push back and say, hey, we're doing the same thing, the patient is getting the care. Why is there a disparity between in-person visits and telemedicine visits? Because telemedicine visits have just been shown to increase compliance, help us manage some of these difficult patients who sometimes have to take off work. They don't have a caregiver to drive them to the appointment. It's just conducive all around. It helps to decrease hospitalizations and emergency room visits as well. So to me, it's a win-win for them.
Makes sense.
In the long run, it will decrease healthcare utilization and save them a lot in cost.
So is it a very large disparity where it discourages physicians to be more on the telemedicine side?
Yes, so it's a very, very big disparity. And because a lot of times, most of our contracts, we have some value-based contracts, but most of our contracts are fee-for-service contracts. So if a patient needs something or there's something come up, you have to actually have them come into the office. But with telemedicine, I could see people on their lunch break at work. Like I could see you just sitting down here, and 10, 15 minutes, the consultation is done, and then you go back to what you were doing. Some patients have to drive an hour one way to come see me, and then that's just kind of like a waste of time when the issue can be taken care of via telemedicine.
Absolutely, and I've seen personally, I loved it. Where me, my family, I mean, my family's like GI appointments were done via telemedicine. I wouldn't, in the past, I would have never imagined a specialist seeing the patient. Primary care makes sense. But when it comes to specialists, I had to see an orthopedic surgeon. I'm in Houston. The orthopedic surgeon was in Dallas.
Oh, wow.
And he saw me via telemedicine. Great experience. I mean, pinpointed exactly the issue I had, got it fixed. And then I told others about it. He did the same thing for them as well. Got via telemedicine.
Nice.
And the orthopedic surgeon is all the way in Dallas.
Yeah. So it improves access to care. It simplifies the doctor-patient visit. It's a win-win situation. But like I said, insurance drives a lot of what we do. So we're hoping that the government steps in and makes telemedicine a permanent policy.
Yeah, I think more than that, I think insurance companies should definitely look into that too, because it's a win-win for them too.
Yes.
So because a lot of times I see it a lot of times where by the time a patient is trying to get an appointment with the physician, it's like you said, there's no such thing as a walk-in clinic anymore.
Yes.
So unless you go to an urgent care, you have to wait a long time.
Yes.
Till then, it can be an emergency. If you don't get to see the physician on time, guess where they're going to go? They can go to the
emergency room. And sometimes it's ridiculous.
So much more.
Yes, and it costs both of them. It costs the patient more, and it costs the health insurance more. And sometimes I have colleagues who are emergency room physicians. Some of the cases that they tell me they see, those are not really emergency room.
They're not emergent.
Yeah, people are going there for sinus infections or refill of their blood pressure medicine just because they couldn't get into their doctor or a scheduling conflict. Like a patient has told me before that, hey, Dr. O, I couldn't take off work. I've taken off work too much this year. My employer told me if I take off one more day, I shouldn't come back. I'm going to be out of a job. I needed my medicine. I had to go to the ER. So it was between going to the ER or not taking their medicine or losing their job, and those are not good options.
I definitely think the insurance companies will come around and say, okay, this makes sense. Telemedicine is definitely needed at parity for sure.
Yes, right now they're kind of following the penny wise pound foolish approach because they don't see how it's saving money on the back end. If we can keep these patients away from the emergency room, if we can prevent them from being hospitalized, prevention is always cheaper and better than cure.
That makes sense. So that's a very good segue into the insurances. You mentioned fee-for-services.
Yes.
And you also mentioned value-based contracts. Can you go a little bit deeper into both of them? And then also, what do you personally take in your clinic? And do you suggest other physicians to go that route too?
Okay. So basically with the fee-for-service route, you just get paid when you see the patient. So if the patient comes in for the 3 months checkup for high blood pressure or diabetes, you see the patient and you send a bill to the insurance companies and then you get paid. So that's why I said in that model, there's a incentive to bring the patient in, because if you don't bring the patient in, then you don't get reimbursed for your services. You might talk to the patient on the phone or do other things. You don't get reimbursed for your services unless the patient comes in for a physical visit. With value-based care, it's a little bit different. There are some different models of it. There's a capitation model where you get paid a certain amount every month for taking care of a patient. So you get a bonus or a reward if you're able to keep the patient within that set amount. So I'll give you an arbitrary example. Like you might get paid $100 a month for taking care of a patient. So it's a risk-based model in that if the care for that patient costs more than $100, you get dinged.
Right.
If the care for the patient costs less than $100, you get a bonus. Wow. So it's a risk model where you are taking on some risk. So the thought process behind that model is the primary care physician is incentivized to keep that patient away from the hospital, keep that patient away from going to the emergency room, try to avoid ordering unnecessary tests, try to avoid unnecessary referrals to specialists, and by that way kind of cut the cost of healthcare. So I would say at this point, most of my contracts, majority are fee for service contracts, where we get paid per visit with the patient. Well, gradually there's a shift in the insurance field more towards value-based contracts.
Fantastic. So, and also it sounds like it's better for the patient because you're keeping the patient healthier because you have an incentive to ensure that they stay healthy rather than you see them again and again.
Yes, and there are different facets to it. You have to make sure that they are picking up their medications and taking their medications. You have to make sure that they are up to date on their preventative health, make sure they've had their colonoscopy, make sure they've had their routine eye exams, make sure they've been to the dentist. So there's a lot of emphasis and focus on preventative care, so that if there's any underlying problem, you can catch it at an early stage before it becomes a problem where they might need to end up on dialysis, which is a lifelong commitment, or they might need to have an amputation or things like that. That will increase the cost of care. So there's a lot of responsibilities on the primary care physician in that setting to drive the care and lower the cost of healthcare. So in that scenario, I like to call the primary care physician the quarterback of the care, because they are the ones directing most of the care.
Fantastic. In terms of in terms of your practice itself, you going, I mean, that's a lot. There's a lot here. Insurance companies, how much they pay, who's taking care of, who's looking at it from a back end? Do you have like a practice management company you use, or internally you have a practice manager?
So internally, I have a practice manager who kind of does an overview of the practice, because like I said, giving the patient the care is just the easy part. The difficult part comes in sending in the bill in and make sure you actually get paid for the services that you rendered. A lot of times you can get denials for different reasons. You can get denials that the patient wasn't covered by the insurance at that time of this service. You can get a denial that the services provided were not medically indicated, or you can get a denial that service is not covered by the insurance plan. So in that way, you have to appeal. Sometimes you have to send documentation. So it's a process, and it's a lot of moving parts. You have to make sure that you are staying up to date on your compliance. You have to make sure that you are staying credentialed with all the insurance companies, because periodically you have to re-credential with them and update your records with them. So it's a lot of moving parts and a lot of things that need to be looked into.
So when it comes to collections, you use a third-party company, you do that in-house as well?
We try to keep it in-house. Like I said, we are a family-oriented practice. We try not to send people to collections, so we try to work with them. A lot of times, depending on the socioeconomic status of the patient, we write off a lot of some of that debt. We try to work with payment plans with patients and just make a monthly plan where you pay $20 or $10 until your balances are taken care of and things like that. So we really try to avoid using collection agencies.
Fantastic. So if they're going to pay on a monthly basis, do you put them on like an auto ACH, or how does that happen?
So what we do is we tell them, okay, when is a convenient time of the month to call you? Is there a certain day where you get paid, or is there a certain day that works for you? And then on that day, they just get a call, and we ask them, okay, how do you want to make the payment this month? So they might get a call on the 15th and say, okay, how do you want to make a payment this month? Some of them might say, hey, I'm just going to stop by on my way back from work and drop off cash, or they might give us a card number to run, or things like that.
Oh, fantastic.
Yeah, so
you have to follow up.
Yes, so we try to, so we'll make a notation in their chart and say, this person wants to be called on this day, or this person said that they will come in on this day. So if that day comes and they don't come in, they'll get a phone call and say, hey, is everything okay? You were supposed to be here 2 days ago. What happened? And all of that.
No, fantastic. So So that's fantastic. Do you think that in terms of collections and things like that, can AI help with that? Because I know it's a very complicated process. It's a lot of denials. You have to go back and forth with the insurance companies. You think with the use of technology, those things will get better over time, or?
Definitely. So 99% of the time, the best thing to do is to accurately verify their benefits. So when you verify their benefits, that's when you kind of find out about 96% of the problems. So that's when you will know if the insurance is active. Because sometimes we have some scenarios where a patient gets fired from a job or they get let go. The next thing that clicks in their head is, oh, my insurance is going to run out at the end of the month. Let me run to the doctor. And some employers are different. Some employers terminate the insurance immediately the client gets terminated. Some of them wait till the end of the month. So in those scenarios, accurate verification of benefits is key, because that's when you find out if the insurance is active or if it's inactive. If it's inactive, you have to talk to the patient about making alternate arrangements. We try to have an affordable cash pay rate for uninsured patients or patients who are underinsured. So accurate verifications of the benefits is very, very important. And at that point too, that's when you determine the patient responsibility. So you don't want a situation where the patient responsibility, their copay or their deductible was supposed to be $100 and you only collected $20. And a lot of times when the patient is in front of you, that's your best chance of getting payment.
Makes sense.
If the care is rendered and you try to call them 3 weeks from now and say, hey, we made an error, you're supposed to collect $100 instead of $20, your chances of collecting that money
Much lower.
much
Lower.
So I think AI will have a great role in helping us verify benefits in real time accurately, because sometimes we do have some software that we can verify benefits with, but in some of these smaller insurance plans, like if it's a mom and pop business of maybe less than 30 or 40 employees, they might have like a very limited plan or an indemnity plan. You're unable to verify that. They're unable to verify that through the software, so you actually have to call.
No, I see.
And that phone call might be a 30, 40-minute conversation. So a lot of times what we try to do is we try to verify the benefits a day or two before, so that way when the patient comes in, they already know the responsibility. If we need to get some new insurance from them, because people change jobs, insurance is changed, we can call them and say, hey, we see you have an appointment tomorrow, but we checked your Blue Cross, it's not no longer active. Do you have a new plan, or what happened? And they can say, oh yeah, I changed jobs, this is my new card. So by the time they come, it smoothens the process and there's no delay, and they can come in and out without any issues.
No, this is great. So in terms of where you guys verify this information, you said you guys have a software.
Yes.
Is that proprietary to your office, or is it a free software?
It's a free software called Avality. So different EMRs also have the ability to check insurances. But like I said, sometimes the information might be a week or two behind, and it's not real-time information. Like I gave you the example, if somebody getting fired and going straight to the doctor's office, you might check the insurance and it's showing that it's active, whereas it's inactive. So verification of benefits, it's a big step in collections.
No, makes sense.
Yeah.
Now let's get to, besides just seeing the patients.
Yeah.
Is there other aspects to your practice anyone can add? Because let's say, this patient is going to be going somewhere else or be doing something that you can definitely see them for as well. So it cuts down their time.
Yes.
And also you get them a service. Like, is there any services that you see in terms of for a primary care or internal med doctor that can, that could take advantage of?
Yes, there are a variety of services that can enhance the patient's experience and also cut down on them having to take off another day of work or having to drive somewhere else and all that. The first most important service I will say is having an insight lab. That just makes the process easier. 95% of my patients are going to have lab work done at some point. So instead of having them have to drive somewhere else to go to Quest or LabCorp and all that, having a lab in-house just enhances the patient experience. So after they're seen, they can go get their blood work done and they don't have to drive somewhere else. Or get lost trying to find a lab, or they get a phone call and then they end up not going, or things like that, or they go there and there's a long line and they don't end up getting the blood work done. Also, there are so many other ancillary services that can be added that can also be a source of income to the practice, as well as enhance the patient's experience. So things like allergies, allergy testing. We are in Texas, where allergies is a huge problem. I see so many patients for allergies, and unfortunately we don't have enough specialist allergists to go around.
Absolutely.
So allergy testing is something that a primary care practice can do, and like I said, it can be a great source of income to the practice, as well as help the patient deal with their allergy issues. And then there are other things like x-rays, doing EKGs, and other testing that these patients will need during their routine care that can be done in-house. And it will be a source of income to the practice, as well as a convenience for the practice, for the patient, where they don't have to take off another day and go somewhere else, or,
Makes sense.
or have to spend a lot of time in a different office.
That's fantastic. So there's certain allergies that you can take a benefit from, but labs is not, correct? Like, because that's like a restrictive service or some sort of...
Yes, so with due to the STAC laws and things like that, the laboratory service is not an income-based service for the practice. It's just a convenience for the patient.
Right.
But there are also in-house labs that can be done that the practice can take advantage of, like strep tests, flu tests, urinalysis, and things like that, COVID testing and all that.
Right.
Those are lab testing that can be done in-house that the practice can take advantage of for standard lab tests and other investigations. It's just pretty much a convenience for the patient.
I love it.
And they love it, because a lot of times patients come and say, oh, in my previous practice I had to go somewhere else. I'm happy that you do it in-house. I like to call it the one-stop shop.
No, I love it. So it's a very good way of thinking of it, one-stop shop, because a primary care should be a one-stop shop.
For sure.
I love it. So so this is the last question I'll ask.
Okay.
AI. It's a touchy subject all across in every industry, not only healthcare, non-healthcare, everywhere. Where do you think AI will play a role for primary cares or internal meds? Is it going to help you guys, hurt you guys? Please, dive into that. Please.
Okay, I would say AI definitely has a big role to play in medicine, but I would say not actually in primary care, probably more in specialty care. Because in primary care, you're looking at a continuum of multiple conditions over multiple years. So you need somebody who is going to look at everything and look at the particular situation that that patient is in at that time. So over the years, you develop relationships and you develop mannerisms. You get to understand the mannerisms of your patient. There are some patients that I've seen for so many years. I don't need to look at the computer to know what they take or what is going on with them. It's just things that I've developed. I've seen them so many times. I know exactly what's going on with them even before I look at the computer. And I feel like AI is also not going to have that human touch and that human instinct. Sometimes I can see a patient and know that there's something wrong with this patient acutely, where they need to go to an emergency room. Just looking at the patient, because having seen the patient for so many years, I know when something is way off. And you can call it a sixth instinct, or you can call it whatever you want to call it. But you can see something and say, hey, this is not right. You got to go here, or this got to be done. And 9 times out of 10, you will be right. But AI typically is what you put in is what you get at. And with AI, if AI makes a mistake with a diagnosis or something, who are you going to sue? Yeah, it's a program. You can't sue a program. But already, AI already has is already playing a great role in things like radiology and pathology. There's actually research that shows that AI is actually faster and makes more accurate diagnosis when it comes to radiology films, CT scans, MRIs, and actually pathology samples. Yeah, so AI has a great role to play in those areas. At some point, it might have a role in primary care, but I don't think it's now.
Very nice. So that means, from everything that you've told me, what I've heard is job security, essentially. For a lot of primary care.
You can put it that way, because I have patients. Actually, now there are a lot of telemedicine websites or places you can go, and you can text a doctor, or you can have a quick chat with a doctor and get a prescription or get a diagnosis or whatever. But in my experience so far, 6 to 7 out of 10 patients that go to those services still come back to me at the end of the day, because either they're not feeling better, either they were misdiagnosed, because there's only so much somebody can do by texting you or by seeing you through a computer when they don't know you. So when I build a relationship with a patient, I can see them over telemedicine and know what to do. But you're just meeting a complete stranger who knows nothing about your history, and they just see you for the first time, and they have 5 minutes to find out what's going on with you.
Makes sense.
Yeah, so they are under pressure, they don't know you. So I've seen a lot of people being misdiagnosed, or given the wrong medicines, or given a medicine that interacts with something else that they're taking, because it's a quick visit. That person doesn't have they don't have your full history in front of you.
It's true.
I mean, it's nice if you have maybe a sniffle, or you have a urinary tract infection or something like that. Simple stuff here, but complicated things and all that, I will strongly recommend people go establish a relationship with a primary care physician.
So very nice. So I know that, in terms of, obviously there's a role of AI, but how about something like a hybrid? The way I remember visiting your office just on business, and I asked you had your laptop open.
Yes.
And there was like a Zoom or something going on. And I remember asking you, I was like, oh, who's this person? And you were like, oh, that's my scribe.
Yes.
And I was like, that's brilliant. That means that rather than you scribing or having someone in the office scribing for you, you have someone that are taking notes for you that are putting into the chart. So can you go into, because for me, that's like a hybrid.
Yes.
It's not full AI, but you're using technology to assist you while being cost efficient, saving your time, and your focus being the patients.
Yes. So, like you said, we're very busy, and with the constraints with inflation and decreasing reimbursements from insurance companies, we are being asked to do more with less. So that puts a lot of time constraints on us. So something that is very popular right now is the term virtual medical assistants, where you don't have the person actually in office. They will be there through a audio video platform, and they could be anywhere. They could literally be anywhere in the world. And they typically have a medical background. They could be like a medical student, they could be a nurse, they could be a pharmacist, and they are taking notes, and they are making a note out of your discussion with the patients. And they actually now have AI softwares that actually do that. So the AI software will listen into the conversation and actually dictate a note, and put it into a medical note that the doctor can review later on and correct and edit and submit. So there's a role for AI in that, helping with documentation and note taking.
Fantastic. Well, this was great, Dr. Okosun. So thank you so much for being on this podcast, helping our listeners with many questions, or navigating through the healthcare industry as a whole. Also, you being a very successful primary care physician, I'm sure they've gotten a lot of value out of it. I know I've learned a lot. I'm sure they have as well. So with that, thank you so much. And in the future, I'm sure I'll get more questions, and I hope to have you back. So everyone listening, thank you guys for listening to this podcast. We're going to be back next time and bringing in other physicians that are successful in the industry in in certain specialties. So I'm always on the lookout for physicians that are successful. So until next time, guys, I'll see you on the next episode of Practice Unlocked. Thank you.